Hi, Sanjay. Good morning.
Good morning, Dr. Bhai.
So, would you please tell us about the case, little bit of summary of the case you're doing?
Sure. Now, I have this young man who is 21. He is right-handed, and he gives history of first dislocation before 4 years. And after that, he had sort of 3 episodes of subluxations, which he reduced himself. That's what I gather from his history. And the last one was before 1.5 months back. And while he was trying to take his sweater in overhead position, he just popped out, and then he could himself put it back. And that is, in nutshell, his history. He is slightly generally lax, but otherwise he has no history of any other comorbidities like epilepsy or stuff like that.
Any imaging you can show us, please?
Right. Okay. He had MRI
seem
done.
To lost your bet. Guys, can we focus the cameras? Get the pictures, please.
Right. So he had MR scan done, which showed soft tissue Bankart lesion starting from 3 o'clock to 6 o'clock. And he also.
Sorry to interrupt, Sanjay. Would you be able to focus on the images again?
I don't have images.
Oh, you don't have.
I don't have images in the theater, but
Okay.
I saw it. So they are arranging for it. And okay, there are images now.
Sanjay, can I ask you about the positioning of the patient?
This patient is in lateral position with a traction on, and we are roughly about 45-degree abduction, and he has been positioned as if he is falling little backward, so that glenoid is almost horizontal.
Do you always use the lateral decubitus position or any
Yes,
other?
for instability, I prefer lateral decubitus position.
Okay, great. So, yeah, please kick start and let's carry on.
Right. So what I have done is I have gone through his joint. He has a very small hill sac. I have run into a little water problem. Can somebody puncture that bottle, please?
Audience, if you want to ask any questions, please
Right.
feel free to interrupt.
This is a small hill sac. Okay, we are back with the water now. Are you getting the inside picture now?
Yeah, it's getting clear now.
Okay. In 2 minutes, I'll tell you if I need more pressure. Okay, there.
Okay, yeah.
I'm sorry, my camera picture here is little bit hazy. I tried very hard to correct it. And he has no slap here, which I confirmed. Right. And he has a sort of very benign kind of soft tissue lesion here.
Yeah, that's very well demonstrated, yeah.
Right. And I don't think he needs any further mobilization done than what I have already achieved. And can you lift this little bit, please? And he has fairly easy to get through the 6 o'clock position there. So he is slightly loose.
Okay. How's the capsule? Any feel of the capsule? Does it feel?
Capsule is not too bad at all.
Okay.
In fact, it does not require too much of plication, maybe a little bit of shift and we are home.
Okay.
So
the apron looks quite shredded, isn't it? It's not, yeah.
No, this is a really robust capsulolabral complex. I'm quite happy with this actually.
Okay, please, yeah.
Right. So what I'm going to do is I'm going to start with my first anchor. I'm going to use titanium 2.8 millimeter self drilling anchors. So they go in after you.
Sanjay, do you normally prepare the rim of the?
I have tried and prepared that, but the curette which I have and shaver which I have, I couldn't do much. So I'm going to accept whatever is here right now. And okay. I'm going to shift my scope onto the anterosuperior portal now. So
how many portals you have created entirely, Sanjay?
I have created 2 portals. One is anterosuperior and the other one is a mid-glenoid.
Okay. Yeah, the audience can see it very nicely now, actually. Yeah.
Right. So I have put a Vissinger rod in my posterior portal, and now I have shifted my scope into the anterosuperior portal to have a direct view of the anterior rim of the glenoid.
Hopefully that will give a better view of the labrum.
Yes, and I can have little better position to view this area where little bit of a stitch taking the capsule along with the labral will help me.
Okay.
Okay,
Right. Yeah,
so
that's a very good view. Yeah.
so if you can see here,
Yeah.
he has a good cartilage. He is a young man. He has a good cartilage.
That's right. Yeah.
So I'll get my sheath in for the anchor, and this is my
Anteroinferior portal, is it? Yeah.
yes, so
Yeah.
a sort of mid glenoid portal,
Right.
and I'll have a sheath in now.
So what kind of anchors you plan to use, Sanjay?
I'm going to use 2.8 millimeter titanium anchor.
Okay.
Somehow I like titanium anchors here.
So you're not fond of bio anchors?
Bio anchors sparingly are used, but somehow the science behind it is still evolving. And when you see reports of lysis around it and other stuff, you're
Right.
a little bit scared. And this titanium anchors, you can see where you are on X-ray and you can follow it up on it.
Sure.
I am going to gently tap this. I have rested this onto the edge of the glenoid, and
Right.
I have mallet, please. And I am going to just tap it in so that it stays there. And since he is a young guy, I'm going to open the glenoid with a drill.
Okay. It's a good bone quality.
Good bone quality, yeah.
Right.
Okay. Is drill ready now?
Yes, it looks pretty good view here.
Right. Drill तैयार है? एक मिनट. अच्छा. We are running in this. Okay. So while I want to put in this anchor, and then I'll use a mattress stitch here.
Good.
Most of the time in the inferior position, I use a mattress stitch, and all other anchors, I may use mattress or the simple stitch depending upon the condition. Here-
You find that gives you a better grip.
Yes. And my knots are always outside. So the issue of not rubbing onto the cartilage is much less.
Although
And-
you're putting it on the face of the glenoid.
I
you
am
put it more-
resting. I am
Yeah.
resting. I am on the face, but not much on the face. But ultimately, it is my sheath is resting on the edge, and I am going to be on the face with the anchor, but
Right.
not too much in. And I don't have any glenoid erosion here, so I don't have that issue.
Sure.
In recent arthroscopy, February 2013, there is one report by Chinese guys. They have done a lab study on the simple versus mattress stitch.
Right.
And they have found out that the mattress stitch gives you at least 1.5 millimeter of the more height compared to the simple stitch.
Oh, absolutely. No
And,
doubt about that.
and everybody feels that mattress stitch helps you at least in this position. I think we are almost ready with the drill now.
Any questions from the audience?
Jara
guys?
sa hi drill
Please feel free to throw in questions in between if you want.
Ready? Okay. वो दबा के रखो. Okay. I think, la. I think I'm ready with the drill, and you don't have to drill too much. You just need to open the.
Does it have an auto stop or is it?
It has a laser mark here. If cameraman can focus on this laser mark outside. Okay, while this was happening, my, my ship moved, so I'm going to reposition that now. Just hold on, bear with me one sec. Okay, I'm happy with that. Just a tap. Mallet, please. Okay, and then I'm going to drill. Okay. Okay, that's it. If cameraman can focus here, right there, there is a lesser mark, and you don't need to see inside.
Right. Sanjay, we can't unfortunately see it. Any chance you can
Is it
slightly
focused
rotate it? Oh, yeah. Okay. Just yeah. Yeah, that's much better.
Right.
Yeah, thanks.
So you just need to open it up, and these are self-tapping anchors. Can you see this anchor now here?
Yeah, can you zoom in a bit more, please? Yeah.
On the tip, please.
Yeah. Okay, great.
Right. It has a lesser mark here, and it has lesser mark
Right.
at the outer end.
Yeah,
So you can very easily
so this is 2.9 millimeter.
2.8 millimeters.
2.8 millimeter.
Right. So let me just position that for you. Okay, that going in. It is a very sharp starting point, and
Right.
there laser mark has gone in. And I am going to take this handle out.
And that
shift
gives you a
out.
good pull. Yeah.
Yeah, and
from-
I'll check it with the good pull now. So I can just move whole
Yeah,
patient with
that
this.
looks good.
That seems like a good one. Now I'll go back to my posterior viewing portal.
So this is only for your most inferior replacement. of the
Yes,
screw.
yes,
Right.
yes. Suture retriever, please. Right, we are back here. So I have put this anchor at almost 5 o'clock position, and and now I'm going to retrieve both the ends into my anterosuperior cannula.
Okay.
Put some mosquito on that, please. Now I'm going to use a suture parser. Yes, ideal suture parser. Okay. Which has a chia into it, and I come in from there you can see the anterior band of the inferior glenohumeral ligament.
Mm-hmm.
I'm going to tighten it a little bit, not much. So I take a bite there. I have Dr. Rahul assisting me, and he is a great job of lifting this young man's shoulder.
So are you putting your hand somewhere in the axilla, or you're pushing it up in the front?
Now, he is just holding the arm and lifting it up.
Okay. So it's slightly distracting the arm.
Yes,
Yeah.
yes, that's what he is doing. So I have deployed this chia loop now, which I am going to retrieve. थोड़ा प्रेशर बढ़ा देंगे प्लीज,
Pressure बढ़ा दो.
थोड़ा क्लियर व्यू हो जाए. 30 कर दो.
What water pressure are you using, Sanjay?
Right now it was 20, I have gone to 30 now.
Right.
Okay. And then in this chia eye, okay, just bear with me, I have run out of water. Okay.
What kind of knots will be applying?
I use a sliding locking knot, and I use a Nicky's knot.
Nicky's knot, right.
It is quick and small, and it is equally effective. So we are shuttling this, one of this suture. ले लो ये. Right, and again I'm going to use the same, ideal suture.
So you pulled it out from the inferior, anteroinferior portal.
Yes.
Yeah.
Right? And then I'll see, this is where it has come out, and second pass will be at the level of the anchor, so that I have a good capsule and labral bite both.
Together, yes.
And then I go back underneath. There.
Yeah.
Okay. Hold that, please.
Sanjay, we are only with you for another 5 minutes. Soon we see this knot. We may have to shift to another talk, I'm afraid.
Okay, and I'll be also here for another 5-10 minutes because it doesn't need more than 2 anchors.
Yes, that's
so
right.
We should be all
It
right
would be
with
nice
that.
to see the mattress knot.
Yes.
And you always try to put that inferiorly, as you said, there's enough evidence now in the literature to confirm better fixation compared to a single simple knot.
Yes. So I'm going to try a knot if a cameraman can focus here, and it is sliding well, as you can see.
Right.
And there are 2 passes here, as you know, and 1 more, and then I'm ready to slide. Right, because of the transmission, there is less light here, but there you go. I'm able to. No, that's okay. That's okay. I don't need. Okay. Right. So that's where
Yeah,
I have
that's your
come in,
sliding.
and now I'm happy with that. And if you just pull the camera here, okay, and I have just locked it. Now I will now throw 3 to 4 alternative half hitches
Right.
just to secure it further. The suture is a very high strength and it does not abrade so easily.
Right.
In India, we tend to reuse these plastic cannulas, and at
Right.
times they have frayed edges. And this kind of sutures, which does not abrade easily by repeatedly shuttling the suture through the cannula, it really helps us.
So the water leakage can be prevented. Do you ever use supplementary radio frequency to slightly shrink if it is lax?
Well,
Again?
I am too scared to use radio frequency inside the joint after I have done anything else.
Right.
So
Good.
I will try and fix my things with the sutures and anchors
Right.
rather than, in short, I haven't used it ever. So
Right.
I'll check it with the probe
Yeah.
and see. Probe, please.
That's pretty good. That looks pretty good fix.
Okay. So
So
I
if-
might put one more anchor here
Yeah.
and get some of this part of the capsule and middle glenohumeral, and then I'm home
May
dry.
I ask the audience any questions for Sanjay, guys? Anybody wants to ask any questions? Well, Sanjay, thank you very much. That was a very clear demonstration. Thank you very much.
Thank you very much for your patience. Thank you. Okay, Biju anchor, second anchor. Mohit, beta andar aa ja.
I think Dr. Sanjay Desai should be moderating the session. Is Dr. Desai here?
दबा के रखना, can you-
Dr. Sanjay Desai. We can have the panelists, please. Dr. Dinshaw,
Okay.
Dr. Padiwala, Dr.
Sister,
Gupta,
खोल दो उसको.
Dr. Pankaj, Dr. Kanchan, Dr. Bhattacharya.
No, I think
It's not.
what we're going to do is we go to the AC joint. Since that's not over.
राहुल आप आ
yet.
जाओ, आप ड्रिल कर लो.
So
All
we
right.
go to the
राहुल ने
the
अभी ऊपर करना जरूरी नहीं है ना,
AC
इसलिए
instruction.
अभी यहाँ पे इतना लिफ्ट करना जरूरी नहीं.
Dr. Deepak Joshi is here. Perfect. So we're going to show you a video presentation on an
Okay,
arthroscopic.
देखो ये मार्क है. जाने.
Sorry. So we go back to the AC joint session now,
Withdraw.
and Dr. Deepak Joshi is going to show
Put an
us
anchor, please.
a video presentation on arthroscopic acromioclavicular reconstruction. And as soon as that's over, we will have the panel discussion on the
ठीक है.
AC joint.
मार्किंग तक जाने दो, है ना? It feels so nice. Indian anchor साला सस्ता सस्ता सब जा रहा है. ठीक ठीक. That's it. Okay. Now what you do is, okay.
We had a case of AC joint unfortunately today.
Now you unscrew it.
So I am going to present a
And then
small
twisting
edited
you pull it
video of the AC joint
You don't need to do
reconstruction
that.
that
That is
was
only
done
for
about a month back at our
Twist-
center
if it
during
twisting,
Delhi
pull.
arthroscopic course.
See, easy.
It was very well done, so I decided to present this video.
Okay. Here
Now-
I am going to use a simple knot.
Short history, this patient is a gymnast. She is 18-year-old. She
But
fell
still
on
I'll
her
retrieve
elbow.
both.
She had lots of
So
bruises
there
around her
is no
elbow,
emptying
and
of the
the
ankle.
AC
See, there-
joint,
sometimes
there
we
was a
have this
top foot
emptying phenomena.
green type 3
So
dislocation
if
of
you
AC
just
joint. It
retrieve
was
both
just
at one
5
go,
days
it
old.
comes.
So we decided to stabilize
Wait,
this
wait.
since this patient was a sportsman. As you can see,
Right.
the patient
Ideal.
is in B chair position. This is the inside picture, that's the outside picture. That's anterior, that's posterior. This is a coracoid, that's the clavicle, this is the subluxated AC joint, and that's the spine of the scapula. The scope is through the posterior, standard posterior portal, little bit lateral, superiorly, this anterior portal is made little bit superior so that the shaver is coming at an angle. That's the biceps, that's the subscap, that's the small MGHL, and
Sure.
the procedure is being started as an
इसको अंदर
debridement of the rotator cuff interval. The capsule is removed, and just beneath the capsule, you can start palpating the
अरे उसको
coracoid. I would like to state at this point that
जो
we
है
are
ना,
doing
क्या नाम
through a
उसका?
70
Mytech वाला
degree
लड़का.
arthroscope. So that's the
आदित्य,
coracoid.
हाँ आदित्य को बुला.
That's the
उसको मैं
coracoid
दिखाना
being
चाहता हूँ कि
cleaned.
ये जा नहीं, कभी कभी जा. आदित्य को बुलाओ बेटा.
As we are going under
वो यहीं अंदर है.
coracoid, we
चलेगा कोई बात,
must
कोई
take
बात.
precaution
चल.
that we don't go medial to this. This is the medial border. We don't go medial because the plexus is just medial to this.
इसको निकालो और
we are
PDS दो मुझे
cleaning the
please.
undersurface. That's the medial margin being palpated.
निकाल दो.
And we should not go medial to this.
एक
This area.
मिनट. Let me use some grasper.
Just that. So next step is the surgery is being done through a 70-degree scope. We can also do it with a 30-degree scope, but we will have to shift the portal to an entro superior, standard entro superior portal for viewing this undersurface of the coracoid. Now this is the passport canal
चल,
being
अबे,
put
now you
now,
try.
so that we can place an AC joint jig. The AC joint jig is as the AC joint jig. So this is the passport cannula. These are very handy. This is an AC joint, variable angle AC joint jig available. This is an Arthrex jig.
Something with the
This is
tip,
placed
grasp.
in the portal.
क्या हो सकता है यार टिप वाला कुछ? आपको
As
ग्रास्पर
we
आई?
are entering, and that's the jig.
वो उससे नहीं, वो पकड़ के नहीं ले
The,
सकते.
the distal border of this jig is at the medial end, and we
keep on
try
trying
to be as close as to the base of the coracoid. And now
चलो
The drill is fast.
ये चलो तो पीछे से निकाल लो इसको चिया
That's
को
a,
खींच लो इसको
since it's a variable angle,
राहुल
Jake,
आप इसको खींच लो
it is we are able to adjust the angle so that we are right at the dead center of the clavicle. Now that's a AC joint, dislocated AC joint. So around a 2 to
मैंने
2.5
ऑपरेशन के
centimeter
पहले
radial to
आदित्य को बोला था कि ये
in the
आइडियल
middle
में
of the width of the
चिया
clavicle.
काम नहीं करता है इसको आइडियल तेरा ठीक है लेकिन बोले चिया 100 टाइम्स यूज कर सकते हैं
The bone and the
इस जन्म में तो नहीं होता है अगले जन्म में हो गया बेटा हो गया बेटा खोल मत
cleaning the
खोल मत
perineum so that the button that we will now will
अब लाइट यहाँ दे दो प्लीज
flush with the
अब लाइट दे दो प्लीज
bone. And this is the 3 millimeter
नहीं कोई ये तीसरा दिन है ना तब वो भी कल रात हिसाब लगाया ना तो थोड़ा
cannulated one. So now what we do, we pass a wire. It's a looped wire, looped
अच्छा
stiff wire is
अच्छा कुछ ग्रासफर जैसा चाहिए
looped
नहीं यार ऐसा नहीं है कुछ
pass
अच्छा पूरा अंदर डाल दे चल तो बाहर
from the
आएगा
clavicle
पूरा अंदर डाल दे पूरा
to
अंदर
the
डाल
coracoid and it will be retrieved through this portal.
4-man
The
शटल
portal that we had.
आप दो व्हाइट स्विचर पकड़ के रखना राहुल जी
This wire. So this procedure is
हो गया,
basically
चलो।
for the acute AC joint.
You know how to
dislocation,
settle, na?
maximum maybe 3 weeks
ओके
old.
और
The
यहाँ
older it is,
जय
the
बताता है
so
ये लाइट करो
in
प्लीज
1 week old, the results are much better. The principle is
ये
that
पंप बहुत ही स्ट्रांग है यार अच्छा है
and
इट इज रियली पावरफुल मतलब 20 प्रेशर में तो उसका देखो
ligaments
वाटरमेलन बना दिया
heal. Sorry, the coracoclavicular ligaments they heal
अब
around
दो
it
में से एक स्विचर आप
and
ले लो
it provides stability. So in a chronic
हम भी
case,
यही करते हैं यार लेकिन डेमो में थोड़ा स्टाइल मारना पड़ता है ना
along
आप
with
भी
this, we
समझो
will have to reconstruct the
उसमें फ्रेड कैनिला दिखनी नहीं
ligament
चाहिए
by
ना
shifting the
तो नहीं लानी पड़ती है
coracoacromial ligament
ठीक है
to the
ओके
clavicle. This is
नाउ
how
ऑल
the
यू डू
wire is being
इज
passed.
पकड़ो अब इसमें ध्यान इतना रखना है इसको ऐसे फीड करना है खींच
It will come out
क्योंकि वो आगे पीछे नहीं उसको पकड़ना नहीं है इसको यहाँ कहीं लॉक ना हो जाए बस।
clavicle
वरना यहाँ
down to
करके
coracoid,
खींच
beneath
लो
the coracoid, and then it will be retrieved.
चलो, ठीक है अब ये आ गया अब दूसरा ऐसे ही रिट्रीव कर देते हैं
through this anterior portion.
इसको रिपीटेडली यूज किया जा सकता है रिट्राइवर दो सिस्टर प्लीज
That's
अब ये जो रह गया अब वो जो आया उसको हम पोस्ट बनाएंगे
what is being retrieved.
और ये जो है छोड़
Transfer.
इसमें नहीं लेंगे क्या जरूरत है हाँ गुड मैट्रेस वी गॉट
So
तो इसमें जो टिश्यू से निकलता है राहुल उसको पोस्ट बनाना पड़ता है
this.
सेम निकी नॉट इट इज वेरी इजी एंड वेरी लो प्रोफाइल सिंपल नॉट
So
कुछ नहीं
the
करना
idea
एक
is
ही
this is
चीज
basically a railroad wire. Whatever we are passing the implant.
आई लव दिस नॉट
Either we can, if we are using tight rope, we have to pass it from the clavicle to the coracoid. If it is say, like in this case, is the washer that the dog bone we are using, being used here, and you can see how it looks like.
ठीक है
So once this wire is out from this, we are trying to. This is being removed. The cannulated drill bit, the 3 millimeter cannulated drill bit is being removed. The importance is it should be the when we pass this bit, it should be straight. It should be in the center of the coracoid. It should not be
चौधरी साहब है ना
basically on the edge of the coracoid, and it should not come out at an angle. It should come out perpendicular. So that's the dog bone. This is an Arthrex product. You can see this is a curve, and it has the 2 slots. So into the
सबसे बढ़िया इंस्ट्रूमेंट लाइफ में ये मिला है
fiber tapes are being put.
चलो प्रो प्लीज
You can
देखो
see
इसमें
how
नॉट
it can slide
पीछे
into
रहा।
this little bit socket.
दैट इज व्हाई यू नीड टू अगर मैट्रेस लगाते ना तो ये सब सोचना ही नहीं देखो एक इसीलिए मैट्रेस ऐसे भी अच्छा रहता है मैट्रेस ही का देखो एवरीथिंग इज फिक्स्ड तो ऊपर से देखेंगे ना तो वो जो वैली जैसा दिख रहा था ना
Put it
पहले
in a normal
वो भी
washer.
चला
So
जाएगा
these are the 2 fiber
We'll see.
tapes.
फ्रॉम टॉप अब पीछे जाना नहीं है तो मैं हाँ एथिलॉन दे दो बस और जय तू फ्री You remove all instrument. देखो,
This is how the two
Look at
fiber
this.
tapes are now
look at
into
this.
the.
जो ये नहीं गैप दिख रहा था ग्लेनोइड के चला गया. This they should have seen actually.
So this is how this,
Now probe though please.
this is how it looks like. Now this will be railroaded from
देखो.
this anterior product. This will go below
See
the
that?
coracoid.
This is इसका problem solve है बस. Okay, thank you guys. Thank you, Dr. Ganesh.
How it is being
I
railroaded.
sorry, I had so less time. I would have
Go from
mentioned
this anterior
your
portion
blood pressure. This is
below the
amazing.
coracoid, and the threads will
I
come
never
out.
had any difficulty because of that. Fantastic, यार. Thanks a lot. क्योंकि ये बहुत इम्पोर्टेंट रहता है. हाँ, लेकिन यार हर कोई एनेस्थेटिक नहीं दे पाता है या देता नहीं है, पर जो भी है.
From here, dog bone will, the washer will